the logistical stuff.
Welcome. So Dr. Tina Beck graduated from Campbell University in Buies Creek, North Carolina in 2011 with her Doctorate of Pharmacy and a Master of Science in Clinical Research. After graduating, she worked as an independent in an independent pharmacy near the beaches of North Carolina for 1 year. She completed 2 years of pharmacotherapy residency at the Fike School of Pharmacy and joined the faculty at University Incarnate Word in 2014. She has been with the Family Medicine Inpatient Service since 2015. Her areas of interest are infectious diseases and anticoagulation.
All right, guys, so today we're going to talk about asymptomatic bacteria, and the question is to treat or not to treat. And again, this is part of the quality improvement study that we are trying to do a little bit better about asymptomatic bacteria and the treatment for it, or whether we need to treat or not treat. So we're going to define asymptomatic bacteria. On the slides, it will now be abbreviated ASB. We're going to review the 2019 IDSA Guideline stance on where we should be, when we should be treating and when we should not be treating. And then we're going to evaluate some of the literature about the overtreatment of ASB. And then we're going to recommend appropriate treatments with clinical pearls when it actually is indicated for treatment. So asymptomatic bacteria is the presence of more than one species of bacteria growing in 10 to the 5th colony forming units per ml. That's what EPIC will show us as, is the 10 to the 5th per ml, or 10 to the 8th per liter. It is irrespective of the presence of pyuria, so white blood cells in the urine. It doesn't matter if you have white blood cells or you don't have white blood cells. But the key thing here is to know that there is no symptoms of an actual UTI present. And so I would like to, I don't know if Poll Everywhere will work on here. If not, we can shout out the answers. People on Zoom, you can throw it in the chat. What are signs and symptoms? I don't think it's going to work because my logo is not there, but it's okay. So everyone shout out, what are some signs and symptoms of a UTI that you're actually looking for in a patient? Dysuria, frequency, urgency, fever, disorient, no. Discomfort of the bladder. So there's lots of symptoms that we are looking for in our patients to say that, okay, maybe you do have a UTI. But most of our patients, for whatever reason, whether you're in clinic or in the ED, they'll get a urine culture or a urine sample, whether they need it or not, and then it gets reflexed to culture, and then you have all this data, and you're like, what do I do with it? So the prevalence of ASB is actually common for healthy women and adults and children with urological abnormalities that impairs voiding. This is from the IDSA 2019 guidelines. It's not an all-inclusive list, but it just shows you the prevalence of ASB in healthy women, and it depends on if you are premenopausal, pregnant, or postmenopausal, if you are diabetic, and then if you are in the long-term care facility. And as you can see, some of the situations where we're like, we're gonna treat these patients because they have something in their urine, it gets more prevalent, especially when they come from a long-term care facility and you see that urine, you're like, we're going to treat. But as you can see, in men and women, up to 50% of them will grow something out in the urine, irrespective of their symptoms. And what I do want to show you that if you have a long-term indwelling catheter, 100% of them will grow something. Okay, so again, it is fairly common. And it's not only the reason for us to just automatically be like, the UA or culture is showing bacteria, we must treat. So the background and significance of this. So according to the CDC, UTI makes about 40% of antibiotics prescribed in the hospital, okay? And then community-acquired pneumonia and then skin and soft tissue make up the rest of it. So more than half of our antibiotics prescribed in the hospital are related to these 3 infections. But UTI makes up 40% of it. So the inappropriate treatment of ASB leads to unnecessary antibiotic exposure. to patients, which then leads to multi-drug resistant organisms. So when they actually do have an infection, we actually do need to treat. Now our antibiotic choices are limited. We have increased adverse drug effects from the exposure of unnecessary antibiotics, and then C. diff is becoming more prevalent as well. So 2019, the CDC has reported a report on antimicrobial resistant threat. It is not just a US problem, it is a global problem that they are thinking that it's going to be a huge problem for humanity to face. Unfortunately, the bacteria are getting smarter, okay? And they're actually getting smarter faster than we can combat them getting smarter. If you think about COVID, okay, and all the different variations it's gone through as we try to combat it, bacteria are just as likely to be develop resistance. So we have 2.8 million antimicrobial resistant infections just in the US alone. And 35,000 of these patients do die because we don't have antibiotics that we can offer them. And if you add C. diff into these figures, we climb over to 48,000 deaths. So a huge chunk of this is just all related to being a proper steward, antibiotic steward. I'm not going to play the YouTube video, but if you might have seen Dr. Glockenflocken, okay, where he plays the doctor and goes to pharmacy and asks for antibiotics. I think that's what sometimes you guys view me as, okay, as like the harbinger of antibiotics. So that one, the Dr. Glockenflocken goes to pharmacy and asks for meropenem, and pharmacy's like, what are you treating? And he's like, fever. And the pharmacist asks for culture and susceptibilities. I don't have it. And then the pharmacist accuses Dr. Bill for trying to create a super bug that will end all of humanity. And then ID comes along and asks for meropenem, and they get meropenem. Okay. All hail ID. Okay. So they get the antibiotics that they want. So again, this is just a really important step for us to become better stewards of antimicrobial use so that we can save these antibiotics for future infections. And as I show you, I'll go through some of our treatment options, and I will show you UH's antibiogram and show you what our resistance rate is to E. coli, to some of these very common antibiotics, especially that you will prescribe in the outpatient setting in the clinic. Okay. So the question always becomes, though, how do we even get to a urine culture? Like for asymptomatic bacteria, we have something that's saying we have bacteria present, and usually it's a culture that says that. So how do we even get to the culture in the first place? So asymptomatic bacteria and UTI, first thing to note is the similarities between the two. ASB has a positive urine culture just like a UTI. And guess what? Most times pyuria is also present. So you're like, they look identical. They do look identical, again, which is the reason why so many healthcare providers are automatically ready to pull the antibiotic card out and say, let's throw some antibiotics onto the patient's regimen. Differences, though, again, there is no signs and symptoms of that localized urinary tract infection symptoms for ASB versus your patients do with UTIs do have them. So I know for you guys who see me on IPS, you're gonna be like, well, Tina, what about the patient that can't say anything or who's altered, or we don't really have a history of them? What do we do in those situations? We'll talk about that in a little bit. But examples of clinical presentations that causes ED or you guys in the clinic to automatically reflex to a culture is that altered mental status, right? I get that a lot. The patient is altered. They must be infected, right? And they are meeting SIRS criteria. Not saying that they're meeting sepsis criteria by saying they meet Jews, but you're gonna be like, hey, white count's elevated, but maybe they have nothing else. They may have a neurogenic bladder, so you're gonna be like, they can't feel UTI symptoms. They have a spinal cord injury. They have something that their typical symptoms may not be for someone who can actually feel the sensations of different UTI symptoms. They may have catheter present. And as we mentioned on the previous slide, if you have a long-term indwelling catheter, okay, 100% of them will grow something out. Catheters are plastic. Bacteria love plastic. It's a perfectly sticky ground where they can just stick there. And with the constant flow of warm urine coming out, it's a nice juicy breeding ground, okay? And then it's gonna look cloudy in the bag. They may say there's an odor, there's something. Again, these are not all indicative of an actual infection present. And then the history of UTIs. I think we can all think, I'm not going to say her name because it's like Beetlejuice. She's going to end up on IPS next week when I'm there. But we can all probably think of the one patient who has the history of UTIs that comes to the ED and we're like, we will treat again. Okay? Just because they have a history of UTIs again does not automatically mean that they have another UTI at this present moment. And then we always get a urine analysis as well, right? Again, for whatever reason, ED pulls it, you guys decide to pull it here in clinic, but we have multiple things that we look at that tells you maybe we have an infection present. The presence of white blood cell, pyuria, okay? Nitrites, positive or negative, leukocyte esterates, which can be positive or negative, and then the epithelial cells, which is a clean catch, whether you determine did they catch it midstream. So we're going to go over some of these urine analysis components and what are we thinking? Pyuria, okay, this is white blood cells under a microscope. It is common for people to have it without an infection. White blood cells may be in the urine, even if you have an inflammatory process going on, that's not an infection, okay? And again, just having pyuria is not specific for a UTI specifically. We see that in almost 14% of females, they can have a sterile pyuria, which means, again, they have a they see white counts in the urine, no symptoms, and about 3% for males can have pyuria, again, not indicative of an infection. And then what we have is patients with CKD. We showed 30% of them have pyuria. Okay, even on dialysis, if you're like, they don't really make much urine, and they still were able to collect whatever few drops of urine they were able to get, we still saw pyuria in those samples. And again, white cells can be in the urine for inflammatory process. CKD is a chronic inflammatory process in your body, so it does make sense that white blood cells will travel down there. So again, this is not enough. Just because you see a UA with positive white cells is not enough to say, let's pull the trigger for antibiotics. So this is more, again, yay or nay. Does positive nitrites for you when you are practicing influence your decision to say you're going to start antibiotics? So how many of you guys say, yes, it does influence it? And you can be perfectly honest, no judgment. Okay? And how many of you guys say no? Okay, so a lot of you guys do say that it does influence your decision to start antibiotics. What we know about nitrites is that it is positive if there's a presence of this enzyme that certain bacteria produce to reduce nitrate, which is common in our urine, to nitrite, okay? The most common pathogens that produce this nitrate-producing nitrate reductase enzyme is E. coli and Klebsiella, okay? So if you think about it, we're going to talk about when we go into treatment our likely pathogens. The two likely pathogens, they do cause presence of nitrites. But we have found, actually this opinion article got published a few weeks ago saying, is it time to say goodbye to nitrites in the urine dipstick for analysis to trigger antibiotic treatment? And they say, again, there's lots of false negatives, okay? Because even if you had E. coli in the urine, it takes up to 4 hours of being present for actually to be able to detect the nitrite. So if you need the bacteria to be in the bladder for at least 4 hours, which means you haven't voided in 4 hours, to have this enzyme then reduce from nitrate to nitrite. And so if you think about it, depending on your profession, some of us may be like, I can hold my urine for 12 hours, okay, but we don't have time to go to the bathroom. But for other people, they may be going more frequently, so it's hard to potentially get that nitrate positive in the urine. And as well as just because it's negative, you may have a bacteria in there, but it may not be the one that produces the enzyme. So we found that there is a lot of inappropriate prescribing because if it's positive, physicians are like, it's positive, there's bacteria in the urine. If you know that it's E. coli or Klebsiella produces this enzyme, you're like, there it is. We got to start antibiotics. So the opinion article is talking about, again, there's lack of studies on what to do with these urine analysis. The last meta-analysis about the dipstick urine dipstick was from 2004. And they're just saying there's not enough evidence to really know what to do with these positive or negative values. If you look at the specificity and sensitivity of nitrites, they show that if it is positive, there's not a high correlation with it being associated with an infection. If it's negative, also there's not a high correlation of saying we don't have an infection. What they did find in the 2004 meta-analysis is that if you have nitrite positive and leukocyte esterase positive, that had the highest specificity to rule in an infection. But if you only had one positive, it kind of fell in the neutral zone of we don't know what to do with it. So where does IDSA stand? So they first published in 2005 because they realized, and asymptomatic bacteria was from the 60s when I was doing this research, that someone discovered asymptomatic bacteria. IDSA didn't publish guidelines in 2005 related to it and then updated in 2019. The 2019 addresses populations not addressed in the 2005 guidelines. And then what they found was that since the 2019 guidelines, antibiotic stewardship programs across the country have identified ASB as an opportunity for all of us to decrease the inappropriate antibiotic use. So again, this is all gearing towards stewardship. Let's be the antibiotic steward. And don't let me, if you're on IPS, come after you and be like, no, we're not doing that. So there's actually very few populations that we screen and actually treat. The first one is pregnant women, okay? They are recommended to screen and treat. So for pregnant women, the reason why they are one of the few people, even though they have no symptoms, if they are growing bacteria in their urine, that we will treat them is because we see that ASB can potentially lead to a true infection in the future. It can go to the pylo and can affect the fetus and therefore can potentially cause miscarriage or complications in the pregnancy. Your antibiotic selection is based on the trimester or weeks of gestation the mom is at. Endourological procedures. So anyone that's going to go under endoscopic urological procedures, okay, such as that will breach the mucosal lining. So there's going to be trauma. A scalpel or something is going to cut open across the mucosal lining in the urological area. We are going to screen for them. And if they do pop up positive, we're going to treat before their surgery in hopes that we will prevent surgical infection complications post-surgery. And the third one is not a explicit recommendation. It's actually implied based on who they say not to treat. So from 1 month from kidney transplant, because of their high immunosuppressive therapy that they're going to be on, they're going to be immunocompromised. They recommend that we screen and we treat those patients. And again, this was not explicitly stated in the guidelines because in the guidelines, what they say is do not treat is people greater than 2 months or greater than or equal to 1 month post-transplant of kidney. So then by vice versa, we kind of imply we're going to treat if they're less than 1 month out from their transplant. What we found is that around 25% of post-transplant patients had ASB around the first month. And then as you go further away from their transplant, the less likely that they actually will have an infection.
Anything specific about how to screen? I mean, screen with a dip or screen with a culture? Or
so they screen for pregnant women. They're going to ask for they're going to do a urine dipstick, and then they're going to send off to culture just to confirm. Because again, correct. Endological, same thing. Dip before the procedure. Hopefully, this will be done before the procedure, a few days before. Wait for cultures to come back so you can again target your specific bugs. So for pregnant women, if you are thinking about it, if it's positive for nitrites and leukocytes, again, this is a gray area. If it's positive, for leukocytes and nitrates, is more likely to be infection. So they just say empirically start.
From a practical standpoint,
yes,
people are gone, right?
People are gone. Yes,
great communication, great follow-up. People are treated right.
People will treat them. Yes, that is correct. But if you can treat them for these three populations only, and not everyone else, the better it could be. So they do recommend, ideally, we would love for culture responses to come back so you can narrow as much as possible. But again, depending on the situation, as Dr. Nato mentions, you may just have to empirically treat them and then hope that cultures show sensitivity. So who not to treat? And I think we do this a lot on IPS. Patients coming in that are coming from community or long-term living, they're functionally impaired. The IDSA guidelines say don't screen them and don't treat them if they grow without the symptoms. I know we've been getting a lot of falls a few months ago when I was on IPS. Okay, just because an elderly patient is falling does not automatically mean, again, they're infected. It can be on your differential, okay? An ED might be very quick to jump out and be like, let's start ceftriaxone on them. But for you, you can think about just because they fall a lot, it does not mean, again, that we should be jumping to antibiotic treatment. And then the functionally impaired or cognitively impaired, they recommend that you assess or try to find other reasons why they're altered before you pull the antibiotic card. There are lots of reasons for the elderly to be impaired besides just, again, the infection. But diabetic patients, again, on that table before, the prevalence of our diabetic patients is about 10%, okay? But just because you are diabetic, and yes, there's extra glucose probably in your urine, which is food for bacteria, they don't recommend screening all our diabetic patients. If so, in clinic, you probably be pulling urine cultures on 99% of your patients. For other solid organ transplant besides the kidney, they don't recommend screening or treatment, despite the fact that they are going to be on aggressive immunosuppressive therapy as well. And then the indwelling catheter, short and long term, again, because of the very high prevalence of something is going to grow, we don't recommend screening or treating for ASB automatically. For the spinal cord injuries, that's the reason why they have the long-term catheter. Again, they may not be able to tell you the sensation of I have the frequency, I have the burning. They say that they may more include fever. The patient will tell you something just doesn't feel right. Like they can just tell that they're not feeling, their body's 100%. They may have incontinence or leaking around the urine. They may have a cloudy urine. They may complain about back pain. So there's other ways for your spinal cord injury patients or neurogenic bladder patients to try to rule out for symptoms that are not your typical UTI symptoms. But all this is to say, the guidelines are guidelines. It's not the law, okay? So please don't go back and say, like Tina said, don't do it, okay? It's outside of here, no one else knows who I am, okay? It's use your clinical judgment, okay? If you have a diabetic patient and you feel like you need to get a urine culture and urine analysis and urine culture because of they just don't look right or they look super sick, even though guidelines say don't do it, use your clinical judgment, okay? So nothing will ever replace your clinical judgment, not even the guidelines. If you have a patient who is altered and you're like, I don't know, Tina, I don't think there's anything else that we can really think of high that's gonna be up high on our differential for the altered mental status, let's start treatment and see if they get better. Again, if that's the case, that's fine. If you're like, there's nothing else. The patient with the falls, if you're like, upon further investigation, you find out she has 9 cats and all that, and she tripped over when you're like, there's the reason why she fell, okay? Versus, again, just because they keep falling or keep coming back to service or to clinic for falling, it does not mean necessarily that they have a UTI. But if you're like, there's no other reason, we cannot find anything else besides a dirty UA, use your clinical judgment of if you want to treat them. So just a recap of some of the information from the IDSA guidelines. Which of the following patients should be screened and treated for immediate antimicrobial therapy. So you have the 75-year-old patient with the altered mental status and pyuria, 28-year-old female that's 32 weeks pregnant with a urine culture growing enterococcus, but no symptoms. The 45-year-old kidney transplant recipient 2 years ago was when he last grew it, got his kidneys, and he has E. coli growing. And then the 80-year-old patient with a Foley that has a positive culture for E. coli. So I see B, or the second one. So your pregnant patient, remember, if you collect the sample and it's growing something, even if they have no symptoms, we are going to try to prevent complications to the baby or during pregnancy. So what does the literature all say about this? I can keep telling you the guidelines, but where is the actual evidence of what we're doing with overtreatment of ASB? And so this study was from 2015, and they actually surveyed resident physicians, okay, to describe what factors led them to prescribe antibiotics for ASB. And what they found was 95 residents completed it. It was about a 76% survey completion rate. They went from 50 departments, okay, in their medical centers. So it wasn't just family medicine. So they surveyed resident physicians across different areas. Majority of them were the first-year residents that completed the survey. Most of them were male residents. And what they found was that almost half of them, even though they knew we do not prescribe antibiotics for ASB, still said, I went and prescribed antibiotics. And when they looked at what factors triggered the residents to say, I know I'm not supposed to do it, but I'm going to do it anyway, what they found was the patient was female. They were older. Okay, and that was two of the biggest reasons that triggered physicians to say, yeah, I know I'm not supposed to do it, but I'm going to still do it anyway. And then the abnormal UA is what really triggered them. When they saw pyuria present, it led to a 4-time increase in inappropriate management. So again, they saw that white cell and they said, there's white cells in the urine, we're going to treat them. Hematuria led to a 4.5% increase. Do you know that blood in the urine, there are multiple reasons to have blood in the urine besides an infection? We have lots of medications that we can be on, okay? A lot of our patients will be on aspirin. They can be on an anticoagulant. Some chemotherapies, if you're a cancer patient, can lead to hematuria. But a lot of them saw blood in the urine and they're like, we're going to treat because there should be no blood in the urine. And then nitrite positivity led to a 2 times increase again. So even though physicians know not to do it, they still found, again, 50% of them about did it. And then these were the triggers that led them to prescribe. And for a second, I just want to think about your own prescribing habits. Okay, you don't have to say it, but based on if you saw a patient, elderly female, with an abnormal UA, whether it was pyuria, hematuria, or nitrite, how many of you guys, you don't have to raise your hand, but think about if you have prescribed antibiotics, even though they said they do not have symptoms. Okay. So again, we're trying to decrease the use of antibiotics, even though, again, you know better, you're like, I'd rather play safe and treat them. What we found in a 2019 article, which was a retrospective cohort study, okay, they found this was 46 hospitals across a healthcare system in Michigan. They found over 2,700 hospitalized patients with ASB that got at least 1 dose of an antibiotic. And what they found was that 83% of them got inappropriate use of the antibiotics. Again, they had no symptoms, nothing to really trigger them to say antibiotics need to be given. But what they found when they did this cohort study was that, again, the characteristics that triggered inappropriate antibiotics was age. Okay, they found that majority of them were over 65 or the elderly. Next one, altered mental status. Okay, so a lot of them came in altered, and then an abnormal UA as well. What they realized, so this is the previous study showed you characteristics that made physicians pull it. Now this study looked at, we already knew inappropriate antibiotics prescribing is happening, but now let's look at the clinical outcomes related to this. And what they found was that if you treated ASB in a hospitalized patient, it led to 30% longer durations of hospitalization. So length of stay got longer because they were trying to get so many doses of IV antibiotics in before they switched over to PO. Without improvement in clinical outcomes. So again, we did not change the decreased rates of readmission. We didn't change rates of symptomatic UTIs in the future. We didn't change much of anything. And so what this led to again was we are inappropriately prescribing, and in fact, we're making patients stay longer in the hospital. The longer you stay in the hospital, the fact that you can pick up a nosocomial bug. My preceptor, when I was over a decade ago, a student always told me a patient will come into the hospital, fall, break a hip, come into the hospital, pick up a nosocomial bug, and die. And I was like, that seems extreme. But I think you can think about some of our patients who have been in the hospital for a while, and eventually they do pick up a nosocomial infection or a secondary infection during their hospital stays. Now let's talk about the altered mental status, because I have had attendings argue with me that this is the reason why we're going to start antibiotics. So we found a retrospective cohort study again that had patients with pyuria and altered mental status, but no symptoms of UTI again. And the primary outcome to see the 30-day readmission rate in patients who were treated with antibiotics and patients who were not treated with antibiotics. And the secondary outcomes were risk factors for what triggered that treatment, comparing alternative diagnosis for the altered mental status, and then safety outcomes once between the two groups. As you can see, they only included 200 patients, and majority of them received treatment. Only 38 did not receive treatment. And what they found in the primary outcome, whether you got treatment or no treatment, there was no difference in readmission rates. So you may be like, is that a good thing? Because there's no difference. And we're not saying people who are treated are more likely to come back. But at the same time, we're knowing if you don't treat them, we're also seeing still the same readmission rate. And this is for both altered mental status or for a symptomatic UTI for the future. Secondary outcomes, what they found was that patients who did not get antibiotics had statistical difference in finding an alternative diagnosis for AMS. So no one gave them antibiotics and they went on a different route instead of automatically jumping, this is infection. They're like, let's try to figure out what else is causing altered mental status. What they found was if you didn't get it, the team of physicians were more likely to find the source of altered mental status. Most commonly was metabolic abnormalities. The other one was dementia. And then the third one was substance use disorders or substance use as an alternate diagnosis for altered mental status. And then they had different risk factors, again, for patients who received treatment. They looked at age and what was the other one? History of dementia. They had a higher odds ratio of being prescribed, but it was not statistically significant compared to the group that didn't. What they did find was having a positive culture or seeing bacteria in the urine. It was statistically significant on that being the trigger that caused physicians to prescribe antibiotics. But again, we're seeing you can probably get away with not prescribing antibiotics and the patient's still doing pretty well. So this leads to, for altered mental status, which of the following drug classes can contribute to altered mental status in older adults? So anticholinergic, benzos, TCAs, opioids, or all of the above? All of the above. And so what that also brings into fact is that we have polypharmacy usually going on, okay? This is from the CDC that shows you as patients age, the number of different medications they are thrown on. And so when you have more medications thrown on, okay, the more likely you're going to experience a side effect of some kind. And then this is polypharmacy. Another drug will be thrown on to try to treat the side effect instead of discontinuing the offending agent. And so as we can see, the older we get in the United States, there's lots of different drugs. Obviously, ACE blood pressure medications, probably necessary. Statins, depending on the age, maybe, maybe not. But as we get more and more drugs on board, this can lead to a lot of polypharmacy, drug-drug interactions that could lead to altered mental status. So again, before you pull that antibiotic trigger for someone altered mental status, what I do when I'm on IPS, I look at the drugs, home meds, and what they're on to see, is there something going on here that can affect CNS? Or do they have already underlying dementia, as we mentioned? Just because they have underlying dementia, this may be a new baseline for them. There may be something else going on that's triggering them to be a little bit more altered than normal. But again, it doesn't automatically mean infection. So now for treatment options. So just as a review, which are the 3 populations we should be treating for ASB? Pregnant women, a urological procedure with mucosal trauma. So you're going to expect trauma into the mucosal lining. And then the implied one was kidney transplant within 1 month of getting their new kidney. So if you feel like you need to treat ASB, these are your options. And we're pretty much following the IDSA uncomplicated UTI guidelines at this point. News update. Later this year, the IDSA guidelines will update their UTI guidelines. Very exciting. Very exciting. I'm excited to wait for it. And there's talks about men will no longer be considered complicated UTIs in the new guidelines. So do you want to bring this up? If you go to the intranet and you go to pharmacy, the Department of Pharmacy, and you go to antimicrobial stewardship, we do have a policy in place on how to treat UTIs per UH policy. But here specifically for asymptomatic bacteria, I do want to tell you that it is also listed. So again, positive urinalysis and or culture without the presence of symptoms, they're saying they don't recommend treatment because, and they give you the rationale, there's no improved outcomes, longer hospitalization, and then they're saying it's in line with the IDSA guidelines. So again, if you are ever interested in some of our antibiotic policies or recommendations and how, if you're like, how does you know that? Sometimes I can just look on the internet and be like, per our policy, this is our drug of choice. So the most common etiology for UTIs is going to be your gram-negative. E. coli makes up about 73/4 of them. Some studies even go up to 90% of it being our most likely pathogen. And then you have, if it's uncomplicated, you have Kleb pneumo. Again, these 2 will produce that nitrate reducing enzyme. So you will be nitrate positive potentially in the UA. And then you have the 2 gram positives. You have Staph saprophyticus, an Enterococcus species. And then for complicated, you have those fungal infections. Super rare to have a true fungal UTI, guys. So it's super rare, unless you have like a giant fungal ball in the bladder or you're super immunocompromised. Candida is not my automatic go-to. And then I know I'm going to get the questions, well, what happens if the UA shows budding yeast or Candida in it? Most likely, if the patient doesn't look super sick, you might want to check them for, especially if it's a female, vulvovaginal candidiasis. Okay, they may have a yeast infection, and as they're giving a sample, little pieces kind of flicked off into the urine sample. Your 2 gram positive Enterococcus and Staph saprophyticus will not produce, be nitrite positive. So again, just because it's negative does not mean that you're like, oh, I don't have an infection. You may actually have these 2 bugs that don't produce it. So again, that nitrite debate is up, whether should we be using it or not to determine if we need antibiotics. So our treatment options are going to be nitrofurantoin, trimsulfa, your beta-lactams, fosfomycin, and then I put fluoroquinolones at the bottom because it's really not preferred. So your preference per the guidelines is nitro is first line. Trimsulfa, do not use if E. coli resistance rate is greater than 20%. I'm going to show you our antibiogram in a second. And then phospho. And then alternatives are going to be your fluoroquinolones and then your beta-lactams. But I did put 2 asterisks next to your beta-lactams because it may be considered first line for your pregnant patients. So this is our UH antibiogram, and this is the outpatient one. This is not our inpatient one. Our inpatient one looks disastrous with the resistance rate we have. So E. coli, all the isolates, this does include the ones that speciate out to be ESBL. So as I mentioned for trim sulfa, which is right here, E. coli is 70% susceptible. So we do have a 30% resistance to outpatient trim sulfa. So probably not your go-to empiric drug choice. Now, if you have an antibiogram somewhere else or wherever you go practice, you can look at this to determine your resistance pattern. And then if you look at your fluoroquinolones, Cipro is 76%. So again, we're at a 24% resistance rate to our fluoroquinolones. So not the greatest options for E. coli. So that does make us, again, want to be stewards, save the antibiotics that do work for when we actually need it and not just give it to everyone. We'll see more reds and yellows as time goes on. So nitrofurantoin, I do want to state that when you probably put in Epic or you prescribe, you're going to see different formulations. There's 2 salt forms. You have nitrofurantoin, monohydrate, and macrocrystals, okay? It's 75% monohydrate, 25% macrocrystals. That is your macro bid, okay? And that's the brand that you want to pick, the one with 2 salts form in it. And how you remember that, how I remember, and it's dosed BID, how you remember macro bid, BID, it ends, so that's how you dose it. And there's 2 salt forms in it. Nitrofurantoin macrocrystals, just macrodantin. It is Q6 hours as your frequency. So if you have a patient who is not very compliant, macrodantin is not going to be your best choice. If you do try to do nitrofurantoin macrodantin BID, pharmacy is either going to call you or we're automatically going to just switch it over to macrobid. Things to think about before you prescribe nitrofurantoin for your patients: renal function. If you look at the package insert, and this is what Lexicomp originally had as their renal dose adjustment, creatinine clearance less than 60, it is contraindicated, okay? Now we have more pharmacokinetic data that show up to 30, it will work. And the reason is it's not accumulation. Like every time you hear me say we need to renally adjust, right? We're always worried about the accumulation. They're going to hold on to it. Nitrofurantoin just stays in the urinary tract. It does not go out anywhere, doesn't hit systemically anywhere else. Reason we care about renal function is to get to the site of action. You need your kidneys to pull it into the bladder, especially if you're dealing with an uncomplicated cystitis. Anything less than 30, your drug will not concentrate in the urine, and ultimately you are giving placebo, okay, with some side effects that can happen. So always look at your renal function for your patient. And if they are pregnant, if you're going to give this to your pregnant patient, you got to see where they are in their pregnancy and gestation. Trim sulfa for treatment. We are going to do the double strength tablet. How you know it's double strength? It's 60 to 800, and the ratio is 1:5, or trimethoprim to sulfamethoxazole. Things to think about: the allergies, the sulfa allergies, okay? We do have some patients with true sulfa allergies that lead to Stevens-Johnson syndrome. We had a patient last year that had anaphylaxis to trim sulfa. So watch that before you pull it. The reason why we're not a huge fan of trim sulfa for our population here at FHC is the kidneys, okay? The renal function is huge. The worse that you have renal function, the more likely you're going to see all these side effects pop up. And I know they're going to say, Lexicomp says to do this with the dose based on renal function. Betty and I don't like it, okay? We don't like what Lexicomp has to say because we've seen podiatry do that, send out the Lexicomp's recommendation, and then patient bounces back with AKI, hyperkalemia, all kinds of problems related to the fact that they were prescribed trim sulfa with poor renal function. Potassium. So trimethoprim, I'm not going to draw you the structure, but the molecular structure of it looks very similar to spironolactone, which is our potassium-sparing diuretic. So the body gets confused and says, oh, I'm supposed to hold on to potassium here. So this is why we see hyperkalemia happen a lot, and especially if you have multiple drugs that can increase potassium, you should be cautious with adding trim sulfa. So if you have ACE inhibitors, ARBs, spironolactone for heart failure patients, and you throw on some trim sulfa, that potassium may skyrocket. And then if pregnant, again, how many weeks gestation are they? Fosfomycin. I personally love fosfomycin, okay? It's one and done. If I ever become your patient, guys, I'm a pharmacist. I suck at taking drugs, okay? So give me the least frequent, least amount of drugs possible. Unfortunately, there is mixed evidence related to efficacy related to fosfomycin. One study shows it's just as good as the fluoroquinolones and related to looking at clinical success. So treating the infection and not having recurrence. Another study looked at it and said it was inferior to the fluoroquinolone, saying that we actually did not cure the infection as well, and that we actually saw recurrence of the infection. So the jury is out from the evidence of fosfomycin. Do we like it? Do we not like it? Where right now we're trying to hold on to fosfomycin is for ESBL infections. Okay, we're looking at it for multi-drug resistant infections. That way we don't need to send them to this hospital for carbapenems. Maybe we can get away with an oral option. The evidence is mixed on that one right now as well. Things to think about for your patients for fosfomycin: insurance and funding. It is, quote, the most expensive antibiotic of your first-line treatments. And when I say expensive, the other ones are pennies per pill. This one, for a one packet, which is mixed in water and you drink it, it's about $40 cash price. Okay, and some say $40 is not bad, but if you think about your patient population, $40 may be a lot. You may also see a lot of prior authorizations come through if you were like, I'm going to send them home with fosfomycin. You may get a PA request come through because, again, insurance is saying go with the cheaper option, not fosfomycin. Okay, so this is pretty much first line what we went over. 5 days. Your duration of drugs is really dependent on what agent you pick. It's not like skin and soft tissue infection where we're like the duration is X days no matter what antibiotic you pick. Depending on the antibiotic you pick, the duration is different. So we prefer nitrofurantoin, the macro bid. Again, low collateral damage, meaning it just stays in the urinary tract. It's not going to destroy the E. coli in our GI system. It's not going to cause major issues. Low resistance rate for now. If you look at the antibiogram, there was 96% for E. coli for nitrofurantoin. So we only have a 4% resistance as of right now. If you are suspecting pyelo in the clinic, we don't use it because it does not cross the renal parenchyma. So again, does not get to the site of action. And again, we change from 60 contraindication to less than 30 for your renal function. And then it is avoiding use in your closer to your term date due to hemolytic anemia concerns for a mom. They do say to potentially try to find an alternate in their first trimester. It doesn't really give you a reason why. It just says may want to consider something else in first trimester, but avoid use at 36 to 42 weeks. Trimsulfa, again, can use empirically if we have a resistance rate less than 20. Here in UH, we're 30. So probably not your go-to. Avoid in first trimester. The mechanism of action of trimsulfa, it impairs folic acid synthesis in bacteria. We need folic acid synthesis for babies for the neural development in early trimester. And then after 32 weeks, due to the risk of kernicterus, we don't use as well. And then fosfomycin, again, costly compared to your other options. It is conflicting evidence on efficacy, but it is safe and pregnant if mom can afford it. Your alternative options, pretty much the FDA is saying don't go fluoroquinolones. And again, here we have a 24% resistance rate. There's a good chance you may miss your E. coli going with your fluoroquinolones. And says you can do it empirically if fluoroquinolone resistance less than 10%. Again, we're not there. We've been dispensing Cipro and Levo like water, so we are getting that resistance. And then avoid use in pregnancy due to that tendinopathy that can happen. So as baby is growing in utero and tendons are forming, if mom takes fluoroquinolones, we can cause some tendon issues in baby. Oral beta-lactams, okay? They are inferior in evidence compared to fluoroquinolones and trimsulfa, but we prefer them in pregnant women because for the most part, as long as they're not allergic, least side effects, least concerns to baby. They say to recommend first alternatives until you know susceptibilities. So going Keflex or cephalexin empirically, probably not the best choice. unless they're pregnant. But if you're doing someone for mucosal trauma treatment, we don't really like it. And because they're inferior, if you look at it, the duration is longer. Because we're giving an inferior drug, we're going to give it a little bit longer and hope that it works to wipe out the infection. And that is it related to ASB treatment. Again, recognizing the three populations that we do want to treat. The evidence of us over-treating is not helping our patients. And then if you do need to treat it, there are things to consider as you prescribe your antibiotics for appropriate use. And then for post-survey, if you completed the pre-survey, I will print out a QR code that's for the post-survey, and it will be posted at FHC in the different rooms and on IPS. We cannot email everyone per IRB, so that's why we will I'll stick up the QR codes for post-survey data. But what questions do you have for me? Yes.
Slide. So given that we both are higher resistance, but the beta lactams are inferior, like if you were in a situation, then like, yeah, you're trying to like state empirically, which one would you recommend?
So if you look at our Augmentin is not a good option because Ampicillin, which is going to be equivalent to Augmentin, is at 61%. If you had to pick, I probably would go with the cephalosporins because we look like we're in the 80s to 90s here. So we have, let's see, where's cefazolin? Cefazolin's at an 85%, so we are 15% resistant. Cefotitan, we won't do cefotitan. Cefoxitin, second generation, third gen looks good. So you can probably get away with, and then our cefodoxime. Cefodoxime is terrible. I probably will go either oral second gen, or you may try to get away with ceftonir, a different oral third gen. Since fluoroquinolones are at a 76% and Bactrim's at a 70%. But again, if possible, nitrofurantoin, as long as they don't meet those renal cutoffs or the pregnancy trimester concerns, we love nitrofurantoin if possible.
I have a meeting, but you guys can ask more questions. But before I do, I just want to say thank you for coming to present to us. No, your bio doesn't say that you were in the military, so you probably did not have a unit coin from the military, but this is our unit coin. So this is the highly sought after, seldom presented, but always treasured family and community medicine coin. This kind of marks you as an honorary family physician.
Thank you. If you have any questions, you guys know, you get me on IPS. And we're good to go.